Thank you. Okay.
All right, good topic today.
Yep, diabetic foot ulcers. Should we start with a case?
Start with a case.
Yeah, so got a 69-year-old male, and I was called over to see him because the nurse was concerned that his feet smelled again. He's maintained on thrice weekly dialysis, intermittently takes insulin for diabetes, which got him on dialysis, and about 12 months ago, he had an ulcer on the bottom of his foot, on his metatarsal head, and with good wound care and everything, it healed up. And the last time, honestly, I looked at his feet was probably 3 months ago. He's sitting in his stocking feet, and he tells you that he has prescribed orthopedic or orthotic shoes from the VA because he has neuropathy, but he also suffers from diabetic neuropathy and that he gets burning pain, so he doesn't like to wear the shoes, and mostly he wears socks, which is all he has on today. And you take his socks off and there's a cloud of dust, which is dandruff, because his feet are extremely dry, despite him having 2 moisturizing things that are in his prescription. He says he doesn't use them. And he has a new ulcer on his foot. It's, oh gosh, it's probably 1 to 2 centimeters, and it's probably half a centimeter deep. There's no infection. And he said, "You're a bad doctor, you didn't follow up." So I think the questions on the case, or what that I hope this helps frame me with, is the doctor a bad doctor? And what could have been done or should have been done in the past, and what needs to be done going forward?
Are you the doctor we're passing
I
judgment on?
am. And I'll tell you,
Curious.
if it's a choice between good being a 4-letter word and bad being a 3-letter word, it probably falls into the 3-letter word after I read this article. So anyway.
So anyway, article in New England Journal just 2 weeks ago on diabetic foot ulcer actually changed how I felt about diabetic foot ulcers. Made a big difference to me, and that's mainly because of its impact on people's lives.
Yep.
So you got some statistics here.
Yeah, so 6% of, I think this is Medicare, diabetics will get a foot ulcer. Actually, we're lower here at the VA, and I think some of that is due to some of the things we fight sometimes is the systemic nature of they always get their feet inspected, but the VA was lower. When you think about the diabetic foot ulcer, I guess some of the profound facts that caught my attention about the article, the 5-year risk of death is 2.5 times increased versus if you don't
Once
have
you develop it.
Once you get an ulcer, your risk of death goes up dramatically. If you have a moderate to severe ulcer, 20% of those will wind up in amputation. And the death rate, if you get an amputation from a diabetic foot ulcer in the next 5 years, is 70%.
And they're not sure why that is. I think it's from loss of motility, loss of being able to get to your nutrition, all the things that those can impact on lives. It's interesting to me that I started looking at diabetic foot ulcer as a much more important marker of disease than perhaps even like retinopathy and different things, you know, with all of that. So it really has significant implications on morbidity and mortality. So.
And also it's a marker, this I didn't realize, it's a marker for ER visits, hospitalization.
Cost to the system.
And the cost is nearly what some routine chemotherapy costs for treating solid organ cancers. Holy smokes. I think the United States spent like over $100 billion last year.
Right.
Wow.
I know.
That's huge.
It's amazing. And you know, I think the other thing that changed my mind after reading this article is that I look at diabetic foot ulcers as a chronic disease like COPD, you know, all of those other things, because once you've had one, you're going to get another one back.
Yeah.
You're going to. Even with a good doctor.
Yes. So 3/4 of them heal in a year.
Yeah.
But up to 40% of them reoccur in a year, and up to 60% in 3 years. And so the article made the point that we shouldn't think of these things as healed, but in remission. And that's what changed the way I thought about this patient. Is I probably should have been more diligent about looking at him and barking at him every week about his dry feet.
Yeah.
So risk factors, it's the things that we think about, you know, diabetes, vascular disease, and then also the neuropathy in terms of they've lost the gift of pain.
So you walk with a pebble in your shoe and you don't even know it.
Heart failure and also end-stage renal disease are big risk factors for recurrence. So why do you guys think these things come back?
Uncontrolled diabetes, not good wound care.
Yeah, continued risk factors getting worse, kind of thing.
If the vascular supply to that area was once compromised, it maybe hasn't changed and is still at risk
Yeah,
for the same area.
Yeah, so the things that
same
got
distribution.
Yeah, same distribution.
the things that got them there, the lack of pain, and then the dryness and callus formation. They get pressure. I think I was kind of classically taught that they get a pebble in their shoe, but I think it's probably not a pebble in their shoe as much as it's friction points.
Well, even the article made a point I never thought about, that you can make an ulcer worse by the packing creating a foreign body on that compromised area that's already compromised by vasculature. But I think it also said that, you think about healing often forming a better eschar or better, tougher skin, but in diabetic foot ulcers, the skin actually heals less well than it was before the original ulcer. So recurrence is much more likely.
Yeah. So what are some things we could do to prevent recurrence?
Regular follow-up with PCP.
So when you
With that good PCP.
so what do you want to look for?
You have to do a foot examination.
And so this guy, I yelled at him almost weekly about his dry feet. It was literally dandruff. I mean, he was just so dry, and saying, look, you got to moisturize. What else? 50% of ulcers are on weight-bearing surfaces. So what do you want to do for those things?
Shoes.
Shoes. So this guy was walking around in his socks because, and so neuropathic pain is difficult to treat, but also unloading the foot, trying to take pressure off the ulcer and making sure that our wound care isn't creating a problem, packing it.
And counseling the patient, because so many people come and they are not aware as to how important it is to check their feet at night, every day, if they have an open wound or if they've hurt their feet, because they don't even come to know.
Right.
And then get treated right away.
Again, losing that gift of pain means
exactly.
it can't be a big deal. It's not bothering me.
Yeah.
They don't understand that it's more likely to die from, from their disease now.
Yeah.
So
I think it's extremely important, and there's something to be said for very simply just removing their socks, looking at their feet.
Yeah.
And I think for us, it gets confusing when you talk about, well, what's the proper, I think one thing that causes me stress is what's the proper dressing change protocol in this, and how often, and what material to use, but that's where we have our guest star here today. But I think the thing that our job is to recognize that this is a major marker for disease, and even if you heal it, it's probably has a good chance of coming back. And then you think about, well, gee whiz, if you even think about revascularizing the area, you still have a good chance of being left with neuropathy and calluses and all the neurologic changes that came along. Even though you have better blood supply, it's not going to fix the damage that's already there.
yeah.
So with
All
that,
right.
should we
Should we introduce our guest star?
So I was going to do.
I'm
I was
gonna swap places with you.
We have Karen Hollinger, and
Really good.
hopefully you'll get to interact with her while she's here.
We love having guest stars, by the
Yes.
way.
And so Karen's one of our basically our lead wound care nurse, and I have a joke to start Karen off with.
Oh, I'm sorry, Karen. If I would have known, I would have never traded places.
Do you know the best place to hide $1 from a surgeon?
Wait a minute, I thought you said $100 from an internist.
That's next.
Okay, I don't know.
In a book. Do you know where the best place to hide $1 from an internist?
No.
Under a bandage, which you probably appreciate. And then the best place to hide $1 from a wound care nurse?
I don't know.
You can't hide money from the wound care
No.
nurse. Actually, that was supposed to be a radiologist, but since you're here, so give us some wisdom, Karen.
Well, okay, so hello. I guess I'm talking to lots of folks here. Thanks for having me, Dr. Porter, Dr. Birch. And so I'm a nurse practitioner, so I run a provider-based clinic. I do have 2 certified wound nurses that work with me, but I'm a nurse practitioner. So all of these things they're talking about, I hopefully have a great impact on as well, helping to continually reinforce all the primary care items that have to happen to hopefully keep that diabetic ulcer remission. Regarding these, I'm going to just quickly say something here about what he said. So the dryness. So we know that is the autonomic neuropathy. That neuropathy has 3 forms. And so that dryness is really part of the neuropathy triad. So the lotion, when lotion is prescribed, whether it be ammonium lactate, urea, 10%, it really is just as important as a medicine, because the crack in the skin of a diabetic foot can lead to cellulitis.
Mm-hmm.
So you really, it's not just a minor thing. So that is where that dryness is coming from. The VA has a less percentage because we are one of the few probably the only healthcare system where you actually get shoes, 2 pairs of serviceable shoes with 2 new inserts per year. Make sure your people are getting those. I'm actually on a task force, the PAVE here at NWI, and really we could do a better job, and we are working on that. We have some plans, but that is why our staffs are a little bit less. And on that front, you mentioned something about, Dr. Porter was the one that mentioned the shoes. And of course, the article, the wonderful article that you have to send me more when there's something in JAMA. I mean, I have my own wound journals that I try to keep up on for my purpose. But the thing is if there's ever anything wound in JAMA, please send it my way so I can be helpful to you all. But this totally, like Dr. Porter said, changed my mind. I had just been to conference, Symposium on Advanced Wound Care. It's the premier wound conference in the country every year. And I had not heard the concept of remission. And I actually started using it in clinic the other day. Now I said, Mr. So-and-so, this wound is almost healed, but it's really in remission, And I explained, he said, I believe it. I saw this happen to my dad. I believe it. He really got it. And so we talked about how do you keep it in remission? You keep it in remission by getting those new shoes every year, by having your inserts checked out, by the fact that I ordered him a long-handled mirror from Prosthetics so he can examine his feet every day. Okay, most important. Okay, I'm just trying to address some of the things they brought up. Yeah, so that was that. And then this article, I mean, we could go into wound care. I hate to burst a bubble, but wound care is really like the least important part of my job. It really is. It's addressing the underlying problem. I could pick 20 right dressings for that wound. Okay? It's, do I have the right shoes? Do they need a vascular consult? Do I need to alert PCP and get their A1C down? Do I need to do X-ray, MRI? I mean, the list goes on. This is what I do in clinic. We are not a wound care clinic. We are a wound clinic, full service, interacting with every profession around here. And I hope we do a good job. I think we do. And this was an excellent. I see a research opportunity. Tell me, I could talk on this forever, so tell me when I got to start. I see a research opportunity on this, and because I actually have somebody researching this, and I looked myself on guidelines.gov to see whether or not I could somehow quickly find whether there's a new guideline about this dermal thermometry. But I have a dermal thermometer on order for my clinic. But is it really? Sure, I want it for my clinic so that I can have one more objective piece of data when I go to admit somebody because they probably have cellulitis. But the more important thing is when somebody is in remission, okay, they've had their diabetic foot ulcer, they're in remission. I've discharged them from their clinic. They're just reliant on Dr. Birch and they're every 3 months checked in primary care. Do they have a thermometer that they can take a temperature on the opposite metatarsal heads and continually examine that, just like they're doing with their long-handled mirror? And this article certainly talks to that's like a new and upcoming thing.
I was going to ask you that, because is it an item we can get from Prosthetics? Because they make, you can go to Lowe's and you can get your infrared thermometer.
It is
$20
a cheap deal. So I'm looking into it. I do not have an answer for you yet.
Okay.
You can find it in the grilling section at
Pretty
Menards.
much.
That's where you find it, actually.
Yeah, but there's like an infrared thermometer that you.
Right, it tests the temperature of your
I actually
steak.
was going to bring one today and ask if anybody knew what it was, and I left it at home.
So coming to a place to a lot of the younger physicians than us is I do think that, like Dr. Porter said, if you think of this as in remission, and that, of course, where is healthcare going in the normal world with insurance? Who knows? But at least here in the VA and maybe some other healthcare systems, we could be more about prevention than we were treatment. Because seriously, I don't want to see stage 4 pressure ulcers, and I don't want to see diabetic foot ulcers, and there's ways to prevent them.
Yeah.
And it starts with good screening. I'm going to say one more thing. It's just from a medical standpoint, please remember this is a disease of the vasa nervorum. Neuropathy is a disease of the vasa nervorum, and that motor neuropathy, the sensory neuropathy, and the autonomic neuropathy, the dry skin, the loss of protective sensation, and the shift of the bony surfaces, that's part of the problem.
Yeah,
Thank you, Karen.
great. Thank you
So,
very much.
yeah. So for my
Do you want
patient,
any more specific, like actually, you know, I don't care. You can put a wet to dry on the wound until they come to our clinic. I mean, we have lots of things we can do. We have amniotic tissue, but you know what? We got to offload them. We got to get their blood sugars controlled. We got and we have the best team around here. We got our orthotist right now.
Yeah.
so I think with my guy, what I wish I would have done was told him that he was in remission last time. This time I told him that. I got him something to offload his foot that he could wear. We tried a different medicine, still pending on whether that's going to work for his neuropathic pain, so that he can potentially wear a better shoe. And I got his daughter involved in going over there and making sure she moisturizes his feet.
Good plan.
That is a good plan.
Yeah. So
And
anyway,
is he coming back to see me? I mean, is it?
he's doing better.
Oh,
I think. I hope. I saw it this week and it was
For
better.
now, he's
For
in
now.
remission.
For now. Well, he's headed towards remission.
Yeah,
Still
okay.
hasn't.
He hasn't hit remission yet.
and it is really important to send them to see. Dr. Birch actually likes to take care of a lot of things on his own, and I applaud him for that. But the paring of the calluses back so that we don't have that acting as the rock in that wonderful shoe. I do a lot of paring of so really no visit is a dumb visit. Okay, so always
Good deal.
consult us if you need us.
Awesome. Thank you.
Thank
Karen.
you.
Hey, thanks for coming.
Excellent.